Hello, I'm Xavier Monnet. I work in a medical ICU in Paris University Hospital, in Bicêtre Hospital. And I will ask the question, in whom should we predict fluid responsiveness? And these are my disclosures. In fact, as you know, we speak about the usual, the common, the very daily question, should I give fluid or not to my patient? And about the process that may guide us to take the decision to give fluid or not. And more specifically, we speak about these tests aiming at predicting fluid responsiveness. And you know that today we have many of these tests. And we know that these tests might be interesting for predicting before we give fluid whether fluid will increase cardiac output or not. We have several of these tests, but today it's not exactly the question. The question is in whom we should use these tests, in whom would that be particularly interesting? In fact, the first box of the algorithm should be, is cardiac output too low? It's very important because preload responsiveness is a normal, a physiological condition. The fact that there are some positive indices or tests of fluid responsiveness should not promote fluid infusion automatically. It should promote fluid infusion if there is obvious tissue hypoxia. And so the second box is about the question, is cardiac output too low? Is there some clammy mottled skin? Is there increased capillary rhythm time? Is lactate elevated? Is PCO2 gap increased? Is SpO2 decreased? Then, and only then, I should ask the question, should I give fluid? And it might be very importantly the first message, fluid responsiveness should be predicted only in patients where the oxygen delivery is obviously not in equation with oxygen requirements. Then, to go further, we should ask, why do we or should we predict fluid responsiveness? And here I will focus on the ICU context. The first reason is that fluid is toxic. Fluid overload is harmful. And today it is very clearly demonstrated. Excessive fluid infusion may lead to a myriad of deleterious effects. The most important being the aggravation of lung edema, the increase in lung water, the decrease of organ perfusion pressure, hemodilution, and the risk of intra-abdominal hypertension. And I told you it's very clearly demonstrated. Look at this data from an American database in more than 20,000 patients. The larger the amount of fluid administered at day one, the higher the mortality. And the second reason why we should predict fluid responsiveness is that, and you know that, only half of the patients with cardiogenic or septic shock respond to fluid infusion, and due to the cardiac function curve. So it means that we should not attempt to predict fluid responsiveness in case of obvious fluid losses, in case of hemorrhage, of clear dehydration, or at the very early phase of sepsis, when no fluid has been administered already. In these cases, fluid responsiveness is obvious, and using any of the indices or of the tests of fluid responsiveness would perhaps regrettably delay fluid infusion. And again, I think it's an important message. In the case of obvious fluid losses or related hypovolemia, give fluid and that's all. Nevertheless, here we must ask, in which categories of patients has fluid overload been demonstrated as an important risk factors? The first population is clearly septic shock patients. And you remember the results of the SOAP cohorts, the total fluid balance, the cumulative fluid balance was an independent predictor of mortality in these patients. And the same was observed in patients, specifically patients with acute kidney injury. And the same in this study with 200 ARDS patients. The more you give fluid to these patients, the more they die. Fluids may increase lung water, and it's clear today lung water measured by transpulmonary thermoevolution, as we demonstrate in that study, which is submitted, is an independent factor of mortality in itself. The more you increase the amount of lung edema, the more the patients die. And the deleterious effect of fluid overload has been clearly demonstrated also in patients with intra-abdominal hypertension. So it means that it is specifically in these populations, in these categories of patients, that we should predict fluid responsiveness. That might be something which is important, and again, let's keep that as a take-home message. Fluid responsiveness should be particularly investigated in the case of septic shock, intra-abdominal hypertension, AKI, and lung impairment and ARDS. Then, after fluid has been infused, we should, of course, assess the effectiveness of fluid infusion. Then afterwards, we should assess whether fluid infusion exerted some deleterious effect. It's not our topic today. But then, in the end, what we should do with fluids should perhaps be to remove them. And actually, the goal of fluid therapy today is, in a way, to give as less fluids as possible. This is possible at the resuscitation phase by avoiding excessive fluid administration. It means by giving no fluid without preload responsiveness. But the other way to reduce the total amount of fluid in the patient might be to remove fluid, and especially at the de-escalation phase when the patient has been stabilized and improved by the hemodynamic treatment. But here the question is very practical. Which volume should we remove with diuretics or with ultrafiltration? 1, 2, 3 liters or more? And that question is, the practical question is important because we want to achieve the best fluid status rapidly, but we do not want to remove too much fluid or to remove fluid too fast. To induce hypertension with diuretics or hemofiltration, for instance. Agree with me, this is a daily question. In this study, we made the hypothesis that fluid removal should induce hypertension only if the patient is in a preload responsive condition. If there is no preload responsiveness, decreasing preload by removing fluid should not induce any decrease in cardiac output and any hypertension. And to assess that simply, we conducted that study where before removing fluid at the de-escalation phase of shock, before removing fluid with ultrafiltration, we performed a passive leg raising to assess fluid responsiveness. And we wanted to demonstrate that in patients with preload responsiveness, there was no hypertension during the ultrafiltration, during the renal replacement therapy that was conducted just after. And actually, look at the results. The passive leg raising test was more positive, increased cardiac output more in patients with intradialytic hypertension. And even more, the response of cardiac output to passive leg raising was able to predict intradialytic hypertension or the absence of intradialytic hypertension. I mean that if the passive leg raising test was negative before fluid removal, the probability to present hypertension was very low. And so the idea is that if preload responsiveness is absent, you should safely start fluid removal, but refrain from doing that if preload responsiveness is present. It's another way to use preload responsiveness assessment, not to give fluid, but to remove fluid. Assess preload responsiveness to take the decision to remove fluid or not at the de-escalation phase. Assessing preload responsiveness might be useful when removing fluids at this phase to avoid excessive fluid removal. And with this last message, I thank you very much for your attention.